ticking in the embryology lab. Your chairs today are myself, Rachel Gregoire, and I also have Gemma Arroyo with me. Okay, we have our next speaker, and we have Orhun Isikoglu, who is going to talk to us about Day After Rescue ICSI. Is it an effective strategy to overcome total fertilisation failure? Thank you.
Dear chairpersons, colleagues and participants, my name is Orhun. I'm a final year medical student. In a couple of weeks' time I'll be graduating, so it's an honour to be presenting at ESHRE before officially becoming a doctor. So total fertilisation failure is the most scary and frustrating situation in ART, which can compel practitioners to prefer ICSI over conventional IVF, even in non-male factor infertility. So today I'll briefly compare the two insemination techniques with evidence-based data. I'll then present our own experience and discuss whether late rescue ICSI can effectively overcome TFF. I have no conflicts of interest. So let's first of all consider the current stance of international guidelines on ICSI. The recent ESHRE recommendations consider ICSI in non-male factor infertility as an add-on treatment and do not recommend its routine use. ASRM and NICE guidelines have similar recommendations, and the ESHRE guideline on unexplained infertility also advises against the indiscriminate use of ICSI. And importantly, ICSI is not being shown to improve outcomes in these patients and may even carry certain disadvantages such as increased costs, more laboratory workload, and also the risks associated with oversight manipulation. Despite lack of evidence supporting routine use of ICSI in non-male factor infertility, its use has increased dramatically in Europe over time, whereas conventional IVF, after a continuous decline, has reached and remained stable at around 30%. And if you look beyond Europe, we can see a similar picture emerging, like in America, Africa and Oceania. In the Middle East and certain countries in Europe, conventional IVF is almost never used. Only in certain parts of Asia do we see somewhat higher rates of conventional IVF use. So there's clearly a gap between what the evidence suggests and what's happening in everyday clinical practice. And if you look at the European registry data, conventional IVF has achieved higher pregnancy rates than ICSI since 2008. And what the small advantage that ICSI has before 2008 is likely because of historical treatment patterns when ICSI used to be used for clear male factor indications and conventional IVF for the same thing as well. So is ICSI really better than conventional IVF in non-male factor infertility? In almost every clinical scenario studied, conventional IVF has provided outcomes that are either similar to or even better than ICSI. Two major concerns that seem to prevent many practitioners from using conventional IVF are fertilisation rates and TFF, but both of these parameters are also comparable between the two techniques. Plus, if TFF does occur after conventional IVF, then rescue ICSI is a backup option. Ironically, now a lack of experience may be emerging as a modern indication for routine use of ICSI. As we've already seen in parts of the world, conventional IVF is very rarely used, so there may well be a gradual decline in expertise in performing conventional IVF. In terms of how the two techniques are compared, the ESHRE Alpha consensus provides some valuable key performance indicators, but also contains some pitfalls. So when normal fertilisation rate is calculated, for example, the denominator for ICSI is the number of injected metaphase to oocytes, but for conventional IVF, all inseminated COCs are included. So the comparison is not equivalent from the outset. Secondly, TFF is presented exclusively as an IVF-related issue, but it can happen in ICSI as well. And thirdly, the risk of oocyte damage in ICSI is often overlooked, which is a well-recognised risk of ICSI. So when the techniques are compared, I think it should be made on equal terms. So if we go into a bit more detail about some of these pitfalls when fertilization rate is calculated per inseminated oocyte. ICSI seems to be better since immature oocytes are removed during denudation. However, when we change the denominator to number of collected COCs, the fertilization rates are reported to be similar or even higher with conventional IVF. So this denominator effect causes somewhat a therapeutic illusion with ICSI. And in terms of TFF, it's not an IVF-specific issue. There's 4 major RCTs, and most systematic reviews and meta-analyses have shown similar TFF rates between conventional IVF and ICSI. So that was conventional IVF and ICSI. I'll now move on to how we do conventional IVF in our clinic. Once the COCs are collected, semen is prepared using density gradient centrifugation. About 2 to 4 hours after collection, the COCs are inseminated and incubated overnight. And 18 to 20 hours later, fertilization is assessed by the presence of 2 pronuclei. And any mature oocytes that haven't fertilized may subsequently undergo rescue ICSI. There's also a link for a video prepared by us showing how this is all done, if anyone's interested. And in terms of how we do rescue ICSI, we do late rescue ICSI, and we only do it in cases of TFF. It's done 22 to 24 hours after conventional IVF, using the previous day's sperm sample. Fertilization is then assessed the following day, and any subsequent embryo transfer or vitrification decisions are made on an individualized basis. If we quickly compare early and late rescue ICSI, early rescue ICSI is done about 4 to 8 hours after conventional IVF. Generally speaking, it's got better clinical outcomes, however, it does carry the disadvantages of being less practical in terms of timing and also high risk of polyspermy. Late rescue ICSI is done about 24 hours after conventional IVF. Practically speaking, it's better, it's easier timing-wise. And also, the overnight incubation of oocytes may allow some immature oocytes to reach maturity. However, some of the disadvantages are oocyte aging and endometrium embryo asynchrony, which is why deferred transfer is often considered. Based on our own clinical experience, we also developed our own conventional IVF index. This is a simple and objective way to decide which couples are for conventional IVF and which for ICSI. It uses the 4 basic semen parameters of volume, concentration, progressive motility, and morphology. If a couple has an index above 100,000, then we prefer conventional IVF for them. If below this, we do ICSI. So moving on to a study that we did to see if late rescue ICSI can overcome TFF in conventional IVF. For this, we reviewed about 2,000 conventional IVF cycles in our clinic between January 2015 and June 2025. TFF occurred in 98 of these. 13 of these cases were excluded because of poor oocyte quality or immature oocytes, as they weren't eligible for rescue ICSI. And in the remaining 85 cases, late rescue ICSI was done, involving 329 oocytes. 7 of these cases remained in TFF, and fertilization was achieved in 78 of them. That says 29, but I think that's meant to be 26. So 26 underwent freeze-all for embryo pooling, and embryo transfer was cancelled in 11 because of poor oocyte quality. And in the remaining 41 cases, fresh cleavage embryo transfer was done, involving 48 embryos. And this gave us 2 live births, 2 miscarriages, and 2 ongoing pregnancies. So that's a pregnancy rate per embryo transfer of 14.6% and implantation rate of 10.5%. Of the 2 pregnancy losses in this study, one was in a 32-year-old with a previous history of spontaneous miscarriages. The other one was in a 41-year-old. In terms of the ongoing pregnancies, one's a twin pregnancy at 25 weeks currently. The other's a singleton pregnancy at 27 weeks. In terms of the live births, both were in patients with low ovarian reserves. And if we look at the baseline characteristics of our TFF patients, just a couple of things to highlight here. Ovarian reserve was generally low, and also there was limited oocyte yield. Some general points from the literature regarding TFF. TFF remains in many cases unavoidable, unexplained, and unpredictable. However, luckily it's not always recurrent. And if we look at the two main systematic reviews for rescue ICSI, the early one shows that early rescue ICSI gives better clinical outcomes, pregnancy rates than late rescue ICSI, but delayed transfer improves pregnancy rates in late rescue ICSI. So, in conclusion, the take-home messages are fear of TFF is not a good excuse for routine use of ICSI in non-male factor of infertility. TFF is not unique to conventional IVF, it can happen in ICSI as well. And day after rescue ICSI, so late rescue ICSI, can salvage TFF cycles and allows conventional IVF to be performed with more confidence. Thank you for listening.
Thank you. Oh, sorry. Thank you. That was a fantastic talk. Thanks so much. There's some time for questions. I think somebody's stood over there. If you can wave at us, thank you.
Hi, I'm Dr. Edem Ajir from Kosovo. First, I would like to congratulate for your presentation. I would like to ask, how did you choose the cutoff of 100,000 spermatozoa for a conventional IVF index?
That's just based on our own clinical experience. It's not based on any mathematical formula as such, which is why I guess the true cutoff could very well be slightly below this at maybe at 90,000 or slightly above at 110,000. We don't know, but for us, we find that it works.
Thank you.
Thank you.
Question over here.
Thank you so much for the wonderful presentation. Why were fresh embryo transfers performed and not frozen after late rescue ICSI?
Oh, that's because at the time that these patients were treated, I think kind of our clinic's protocol was to perform fresh embryo transfers, and much of the evidence suggesting better pregnancy outcomes with frozen or delayed embryo transfer came after this, so this wasn't really reflected in the clinical practice at the time.
Thank you.
There's another question here.
Hello. Very nice talk, thank you. I just have a comment, I don't have a question. I just wanted to correct the information with 0% IVF in Middle East, because it's been always presented as such, and it's not true. So we perform IVF, yes, in very maybe low amount and considerably in the area. However, it is done in according to the need. So we have at least 10% IVF in our clinic, but we have many male factor patients, so that's why we do. Thank you.
Okay, thank you.
Thank you. There are more questions over there.
Hi there, Jessica from Germany. Thank you for your talk. I want to ask the semen you take for the IVF, you also take it for the ICSI, the rescue ICSI, or does the man give a fresh probe?
Well, so we use the previous day's sperm sample.
The same.
I understand the kind of lifespan of sperm is long enough that we can do late rescue ICSI and use the previous day's sperm sample. So just for practicality reasons, we don't call the patient in again.
Okay, okay, thank you.
Okay. Here, please.
Hi, Oluwatosi from Nigeria. I was just going over your presentation and I wanted to ask, why would you put the patient through rescue ICSI when you can actually do the ICSI? Because if you look at the data you presented, only 2 live births. And why would you decide to do conventional IVF in the first place? Well, because if you look at the emotional effect, cost, and everything, you have to put the patient through that when you can actually just optimize. Second, I would ask, if you keep the sample on the bench overnight, have you noticed any growth in the semen sample? Don't you think that can also affect the rescue ICSI results?
Yeah, so the ethical side of things is definitely important to consider. However, I just want to reiterate that TFF rates between conventional IVF and ICSI are similar. And in fact, one of those RCTs I've shown you, conventional IVF has a lower rate of TFF than ICSI. On top of that, we should also consider other laboratory parameters. So conventional IVF is known to have either similar or better outcomes in things like implantation rate, pregnancy rates, live birth rates. On top of that, ICSI has higher risk of congenital anomalies, chromosomal abnormalities, higher risk of polyploidy. So putting this all together, I think in non-male factor of infertility, conventional IVF is still the better option. And in terms of our late rescue ICSI statistics, since you refer to them, I agree they're quite modest. However, let's not forget that these patients experienced TFF, so would have had no embryos at all if it wasn't for late rescue ICSI. On top of that, if you look at the baseline characteristics of our TFF patients, they represented a poor prognosis group given their low ovarian reserve and oocyte yield. So if late rescue ICSI can salvage some TFF, some cases in such a group, then I guess that's still, even if it's not effective per se, it gives a glimmer of hope.
Okay. But do you consider... Okay.
Questions? It's a very interesting topic. Thank you for answering. We go